Hello, folks. It's Dr. David Rawson, president and founder of the Canadian Academy of Clinical Sleep Disorders Disciplines. I think you've enjoyed our Wednesday webinar series that we've been running since about September of last year. COVID, as you know, has shut down the ability to have in-person meetings. So we're reaching out in as many ways as possible to continue our service to our members. So our Wednesday webinar series has been highly attended by people all across the country. Today, we're introducing a different format, a discussion with experts in our area to just help us steer in areas that we think would be helpful for you. And today, I'm happy to be joined by Dr. Bradley Lanz of Freeman, Caro, and Lanz Orthodontics in Toronto. And he has an express interest in sleep apnea, obviously in children. And so he's here today to talk to us about his interest and his expertise in that area. So welcome, Dr. Lanz, to the Academy.
Thank you, David, very much for having me. It's an honor to be here with you.
Well, it's an honor to have you, sir. So we have a few questions that we thought would help set up this conversation. And so I would ask you initially, what's the role of the dentist in pediatric sleep apnea?
Sure. So, why don't I start off by just, throwing some numbers out there just so we can get an appreciation of what, who this affects and how many kids are affected by this. So, studies have shown that, there's a bit of a range there, but anywhere from 2 to 5% of kids suffer from sleep apnea. Some of the studies from, that coming out of the orthodontic field peg it at about 5% of our patient population. But most importantly, 90% of them are going undiagnosed. And what they've also found is that upwards of 25% of kids that have been diagnosed with ADHD are actually suffering from sleep apnea. So there's a whole pool of patients out there that just aren't getting diagnosed with sleep issues, and it obviously affects them greatly. So I really see our role as dentists as gatekeepers to be able to screen these patients. We see them on a regular basis. And what I really feel we should be doing is using our screening tools and then encouraging our patients to speak to their pediatricians if they screen positive, to seek the help, to get the referrals to the ENTs so that they can be properly assessed and diagnosed. I saw a very interesting study that just recently came out that while pediatricians are very comfortable dealing with patients that have sleep apnea, upwards of 86% of them are not screening for sleep apnea. And so I really think that that's where we come in to be able to properly screen these patients and then encourage them to speak to their pediatricians about this.
Excellent. So for the dentists watching, listening to us today and perhaps not being aware of this very much, what can we tell them that they should be looking for in their patients to help become more aware of this?
Yeah, so for me, there's when it comes to kids, there's 4 things in particular that I am looking for when I am assessing the patient in the chair. So first is looking at their tonsils. So we know that in kids, which is a little bit different than in the adult population, tonsils and adenoids seems to be the number one cause of sleep issues in children. And so I'm looking at their tonsils, and there's different ways to score them in terms of size. But really, I'm looking at their tonsils just to assess how large they are. Secondly, I'm looking for cross bites. So I'm looking at the arch width, particularly the upper arch, and seeing, are there any cross bites present? Are we dealing with a really narrow upper arch, which may indicate to us that the airway volume is a little bit reduced? I'm looking for signs of wear on the teeth. So we know now more and more research is coming out linking, grinding and bruxism to sleep disorders. And so I'm looking for those signs as well. And then I'm also looking at mouth breathing. Studies have shown that there's a higher incidence of learning disabilities in mouth breathers. And mouth breathing should also be considered a sleep disorder, or breathing that way at night. And we can assume if they're breathing that day during the day, that they are likely breathing that way at night, is not normal. And they should be seeking out an ENT for that as well. Studies show, as far as the tooth grinding, that upwards of 50% of kids and 15% of adolescents may be grinding their teeth. Obviously, not all of them have sleep apnea, which is why it's important to use some other screening tools as well to sort of narrow that down. But certainly those are the four main things that I am looking for when I'm doing my intraoral exam.
Excellent, thank you. So what screening tools might there be for the general dentist to start thinking about using to help evaluate airway issues?
So for me, my number one tool is the Pediatric Sleep Questionnaire, which has been verified and proven to be a very effective screening tool. It can be easily added to our medical history forms when patients come in. It is essentially a 22 set of questions. They're either yes, no, or I don't know. And they really cover everything from snoring to sleep to behavioral issues, going back to that percentage of children that are diagnosed with ADHD, but in fact have a sleep disorder and are not actually have true ADHD. And so this questionnaire covers that range of questioning and allows us to narrow down. And what sort of the studies show us that a 30% positive response to the questionnaire would be indicative of a possible sleep disorder. So when I combine the questionnaire with my physical exam of the patient, that allows me to really narrow down who should be encouraged to speak to their pediatrician and see an ENT.
Okay, and to follow up on that, presumably there must be more specific testing done. Are you aware of what kind of tests might be done by either the ENT or the pediatrician?
Yeah, so I mean, similarly to with adults, sleep study is sort of the go-to in terms of the assessment. We know that sleep studies have their strengths and weaknesses in terms of yes, they can diagnose whether there is an issue, but not necessarily where that issue is. And then so often, the ENT will also incorporate a scope into that as well. So I think the testing itself is fairly similar between the pediatric population and the adult population. Again, we do know that in kids, the tonsils do seem to be the primary cause of the issue, and that's sort of the tonsil and adenoid removal is sort of the go-to as at least a first step in children.
Excellent. I'm assuming that most of our colleagues and probably most patients would have expected that an orthodontist wouldn't see a patient until 8 or 9 or 10 or slightly older. It sounds like you're talking about younger patients. So my question is, are you specifically reaching out to them for that? And more importantly, what's the reaction of the parents when they realize you're actually examining for this and thinking about this as a long-term health consequence? Are mothers excited about it? Are they shocked? What's their feeling?
So, on the first question, I would say that, I use this as a screening tool for patients that are referred to me. And so I would encourage, dentists to do the same. There's no need to, send them to an orthodontist for this type of assessment. I mean, we have access to these patients. We have a relationship with these patients. And so, again, the questionnaire is very easily added to a medical history form, and looking at the tonsils and crossbite, signs of teeth wear, I mean, that's sort of in everybody's wheelhouse here. So I don't think that 3 to 5 year olds necessarily need to be referred to an orthodontist for this. I think really just being assessed at the dentist's office and taking it from there, and whether if there's narrow arches and the orthodontist can be a part of that treatment afterwards, by all means. But for the initial assessment, I think that should definitely be done at the general dentist's office. And then for the second part of your question, I think a lot of parents are surprised a little bit. As we mentioned at the top, while pediatricians seem to be very comfortable, treating these patients and handling the care and the referrals, they're not necessarily screening for it. So sometimes when I start asking these questions and looking for these things, parents will come back to me and say, this is the first time anyone has ever asked about their sleep. Anyone has ever asked about their behavior during the day and relating it to school and patterns. And it kind of, it makes sense to parents when we're asking about that, because, I know how I act during the day when I am tired and how I feel. And just imagine a growing child when they have a bad night's sleep and now they're being asked to sit in class and behave and learn and follow orders. I mean, it just makes sense that they would have a difficult time doing that. And so, So certainly it is sometimes a surprise to parents, and they are appreciative doing that. I mean, I try to word it in not a, a threatening or a scary way, because, to start asking, does your child stop sleeping or stop breathing in the middle of the night can obviously be a scary thing, but they are in general very appreciative that we are, taking this seriously and considering it, and encouraging them to seek further care.
Excellent. This may seem like an unfair question, but we're all aware of what used to be called SIDS, sudden infant death syndrome for babies, youngsters in bed. Is there any indication that maybe this has been going on for a long time and we've now looking at it from a different perspective?
Well, I think, sleep apnea in general has become a little bit of a buzzword, and that's not a bad thing necessarily. I think, similarly to in adult populations where, there is written accounts of this all the way back in the 1800s, but it seems like only now are we really taking this very seriously. I think similarly, in children, it is becoming obviously much more serious. I don't think that there's necessarily more children suffering from this now than there was 20, 30, 40, 50 years ago. We are just much more aware of this actually affecting children. I think we could agree that the picture of the, even the adult with sleep apnea is no longer necessarily the overweight, 6-year-old alcoholic, which, that originally was sort of the picture that we all had with sleep apnea. We know now that
Right.
young, fit adults, can also suffer from this. So I do think that we're just much more aware of it, and we know that children can suffer from this.
Thank you very much. In wrapping up this interview today, and thank you for your time, Dr. Lanz. Um, what message can we send to our general dental colleague communities, the dentists in our community, about thinking about this? We don't want to terrify them that they have to become sleep physicians, but is there a message you have that maybe resonates with them as humans, as parents, as well as dentists, about just starting to ask those questions that you're clearly doing now?
Yeah, I mean, I think, for myself, what brought it home and why I became so interested in this is that, I dealt with it with my youngest son. We took him, we were concerned about his sleep. We were lucky that we had a pediatrician that took that conversation very seriously. He had a sleep study, was diagnosed with severe sleep apnea, which is actually way worse than I thought it was. I knew that, I'd heard him sort of, catching his breath, but I'd never actually witnessed him stop breathing. And then to actually find out that he was suffering from severe sleep apnea was sort of eye-opening for me. Had his tonsils out and really was night and day in terms of behavior, in terms of sleep, in terms of gaining weight, in terms of school performance. So it really is important with these kids. Sometimes, we hear, well, they'll just grow out of it. And I think that what's important to say is that, in truth, they likely won't grow out of it, but they may grow into it. And do we really want all these kids growing into this? Chances are, if they're tired, they're not performing well at school. It's impacting their cognitive functions. And, in children with developing brains and cardiovascular systems, that it is often more severe, the effects that it has on them. And even a few months of sleep disordered breathing can really have long lasting effects. So I think just knowing how serious this is and how many of our patients may be affected by this, should just, again, you don't have to treat them. You don't have to do anything as far as treatment, but to just ask these questions and look at, just a few things intraorally, which we're doing anyways, but just kind of making that link for patients, I think really is a great service that we can be doing for them.
I agree totally. I think we're adding a more of a holistic approach to healthcare that we as dentists maybe didn't give ourselves permission to do because we were just looking in the mouth and fixing teeth and correcting crossbites. But as you said with your own son, what a difference to not, as an orthodontist, not even realize how serious your own child was affected by it, and then to see the difference when you take out the tonsils.
Yeah.
That's amazing. That's actually probably the most important part of this message, Doctor. Thank you so much for your time, and we'll have you back to expand on this conversation because I think more people need to hear it. Thank you so much,
Appreciate it.
Dr. Lanz.
Thank you. Thank you for having me. Really appreciate it.